My name is Rishi Wadhera. I'm the section head of health policy and equity research here at the Smith Center. And today I'm just going to be talking a little bit about health policy strategies to reduce inequities in the United States. As you've heard about before, the United States spends more on healthcare than any other country in the world. But despite how much we spend, our healthcare system performs poorly. When you compare the US to other higher income countries, as you can see on this table, we rank dead last on measures of healthcare access, healthcare equity, and perhaps most importantly, health outcomes. And our poor health outcomes are distributed unequally across the country. This map shows US regions with low life expectancy in red and areas with high life expectancy in blue. And depending on where you're born in the US, your life expectancy might range anywhere from 56 to 97 years. The lowest life expectancies are concentrated in low-income communities and communities of color, which are predominantly located in the southeastern United States, which you can see here. These striking disparities are also evident in our very own backyard here in Boston. Roxbury, a lower income neighborhood, which is comprised predominantly of Black and Latino families, has premature death rates that are more than 2 times higher than Back Bay. These communities are located just 4 miles apart from one another. Given the inequities that plague the United States, our group at the Smith Center has really focused on understanding how we can advance health equity. And the way we do that is we're physicians who have deep expertise in clinical medicine, but we also have formal training and expertise in healthcare policy and public health. And what we do is we combine that expertise with state-of-the-art statistical methods, which you've heard a lot about today, and big data to really understand how community, state, and federal policy strategies that are being implemented around us are affecting healthcare access and quality, social determinants of health, and health outcomes and equity within our community, and of course, across the country too. And I think one of the things that's particularly unique about our group is that we are sought out by and talk directly to policymakers, whether it be at the Department of Health and Human Services, the Centers for Medicare and Medicaid Services, or as you've heard a lot about today, the FDA. And the reason that's important is because it ensures that our research informs policy action at both the state and the federal level. One critically important policy that our group has really focused a lot on over the past few years is the Affordable Care Act, or the ACA. As many of you remember, back in 2010, in what was monumental legislation, President Obama passed the ACA in part to tackle the jarring health inequities that plague our country, which I described to you earlier. And the ACA really had 2 major goals. The first was to improve access to health insurance coverage. And the second was to improve the quality of care that's delivered in the United States. And work by our group, which I'm going to go through in the next few slides, has really helped state and federal policymakers understand whether policies that were enacted under the ACA have worked or not worked. The first major policy initiative that was rolled out under the ACA was Medicaid expansion, which was implemented in 2014. And many of you may remember that prior to the Affordable Care Act in 2009, nearly 1 in 4 working age adults was uninsured. They couldn't get health insurance coverage. They couldn't afford health insurance coverage. And in most states, just to put this in context, an individual making just $7,000 a year could not qualify for Medicaid, which again is the government program that provides health insurance coverage to low-income Americans. Medicaid expansion changed that and really made it easier for low-income adults to qualify for Medicaid insurance. As a result, 15 million adults gained insurance coverage under Medicaid expansion in the ACA. And in a series of research studies, our research team showed that the 39 states that chose to expand Medicaid under the ACA, which are shown in the dark blue on the map, compared to those that did not, which are shown in the orange, experienced dramatic reductions in uninsured hospitalizations, particularly for heart attacks and heart failure. In addition, catastrophic expenditures due to medical bills that were causing low-income families to go bankrupt and inherit debt over generations declined after Medicaid was expanded. And perhaps most importantly, so did death rates due to heart disease. This work by our group and many others has been really consequential because it's shown that insurance coverage saves lives, and it's increased public pressure on states that did not expand Medicaid to adopt this policy, which you're probably seeing in the news right now as states grapple with whether they should expand or not expand Medicaid. But not all policies have been success stories like Medicaid expansion. Like I said before, a second major goal of the ACA was to improve the quality of care delivered in the US because we have suboptimal health outcomes compared to other higher income countries. And to accomplish this, the federal government began requiring that more than 3,000 hospitals nationwide, including all of those in Boston, participate in 3 programs that are called pay for performance programs. And these programs were rolled out nationwide in 2012. These 3 programs are programs that we and our family members are now all exposed to when we enter a hospital. And the rationale for these programs was simple. The federal government felt that imposing financial penalties on hospitals that appeared to be doing poorly would motivate them to improve care. And just to place these programs in context, the financial stakes of these 3 pay-for-performance programs have been immense. They've penalized hospitals nearly $7 billion to date. Unfortunately, our research has shown that these national pay-for-performance programs have not worked, and that maybe they've also resulted in unintended harm to patients. The Hospital Readmissions Reduction Program, or HRP, was one of these 3 major programs that was rolled out, what I would say, experimentally nationwide. And the goal of this program, the HRP, was really just to reduce the rate at which patients came back to the hospital after being discharged, again, by penalizing hospitals with high 30-day readmission rates. But many of us in the clinical community worried that financial incentives to keep patients with chronic conditions out of the hospital might have unintended consequences. And so we explored this question in a study that was published in JAMA and found that although readmission rates fell nationally when the HRP was announced and implemented, shown here in the blue lines, death rates increased nationally after the program was enacted. As you can imagine, this work attracted substantial media attention because it was a case study of how well-intentioned but experimental health policies can result in unintended harm when they're not rigorously evaluated before widespread implementation. And since this study and others that our group has produced, we've had numerous conversations with government officials at HHS and Medicare who have started to rehaul the program, and now, as we sort of emerge from the pandemic, are considering terminating it. Another unintended consequence of these national pay-for-performance programs, the 3, and most notably the HRP, which again, the spirit of these programs was to improve care quality, is that they've all been incredibly regressive. The reality of the US is that our healthcare system is still segregated, and the care of low-income and Black adults really tends to be highly concentrated at a limited set of safety net hospitals in the United States. And we've published work showing that these safety net hospitals have been disproportionately penalized by all 3 national pay-for-performance programs. And so our group and others have argued that taking resources away from already resource-constrained hospitals that are caring for the sickest and poorest patients in the country makes no sense and will likely widen disparities in care and health. I've walked you through 2 examples of how national health policies can either improve or unintentionally worsen health equity and outcomes. But I also, I want to make the case that we really don't have room for error anymore. And that's because the onset of the COVID-19 pandemic has worsened health inequities in the US, and it's really just amplified this need to ensure we get policies right the first time. In March of 2020, and I know Bobby already showed this, but we published one of the first studies in the country to really highlight and put a microscope over the fact that low income and racial and ethnic minority communities like the Bronx in New York City were disproportionately bearing the burden of COVID-19 when the pandemic first hit the United States. And in a subsequent study that was profiled in the Boston Globe and NPR, we showed similar patterns across cities and towns in Massachusetts and found that being a food service worker, not being a citizen, and housing density were the factors at the community level that were driving these racial and ethnic disparities in COVID-19 cases and deaths. It's worth noting that there have also been substantial collateral harms from the pandemic. For example, we found that deaths unrelated to COVID-19, like heart disease and stroke spiked during the pandemic, as you can see in the red on this graph, likely due to reduced access to healthcare during the pandemic, healthcare systems being overwhelmed, and fear of coming into the hospital due to concerns about contracting COVID-19, again, at the height of the pandemic. And what's even more concerning is that the spike in deaths that we observed in heart disease, for example, were really primarily concentrated in racial and ethnic minority groups. So although our work has shown that the pandemic has had adverse short-term effects on the health of Americans, there's reason to be even more concerned about the long-term effects of the pandemic. And that's because this public health crisis has also created an economic crisis. Poverty, unemployment, loss of health insurance, social isolation, housing, food, and food instability, all of which are social determinants of health, and so they are deeply intertwined with health, have fallen more heavily on families who were already struggling before the pandemic began. And let me just attach some numbers to that. 1 in 5 Americans lost their job at some point during the pandemic or had someone in their household lose their job. 63 million adults can't afford to pay for their household bills right now. And 20 million families currently don't have enough food to eat in their household. And so I bring up all these statistics to highlight that we're really at a tipping point where health disparities in our country may be on the cusp of getting much, much worse as we emerge from the pandemic. And so really now more than ever, there is an urgent need for research that will allow public health officials and policymakers to figure out what are the most effective ways and tools to mitigate the long-term adverse effects of the pandemic and advance health equity in the United States. Thank you very much.